Hello, welcome to the Canadian Geriatrics Society student podcast presentation, which is sponsored by the National Geriatrics Interest Group and the Canadian Geriatrics Society. I'm Dr. Roger Wong, President of the Canadian Geriatrics Society. I'm also a clinical professor of geriatric medicine and the postgraduate dean of medical education at the Faculty of Medicine, University of British Columbia in Vancouver, Canada. It gives me great pleasure to welcome you to this very special podcast presentation on geriatrics and healthcare in Canada. We hope that you would enjoy this presentation. Upon completion of this podcast presentation, we hope you will be able to discuss the opportunities and challenges of geriatrics in healthcare in Canada in terms of health services delivery, scholarly and research productivity, education, as well as health human resource planning as it pertains to geriatrics. As we all know, the population in Canada is aging. More than 13% of Canadians are over the age of 65, and the first cohort of baby boomers turned 65 years old in 2011. These seniors all have an increased healthcare needs that require skilled medical care. The domains of geriatric care involve not only the biomedical care for seniors, but as well as functional care for seniors, cognitive care for seniors, as well as addressing the psychosocial needs of this population. The formal definition of comprehensive geriatric care is well described in the literature and is beyond the scope of this podcast presentation. However, as geriatricians, what we do every day is to identify, trying to resolve, as well as prevent interactions that may be potentially reversible. And these include drug-drug interactions, drug-disease interactions, as well as disease-disease interactions. There are many providers of geriatric care in Canada. For instance, doctors in the area of family medicine, internal medicine, psychiatry, and a variety of surgical specialties all deliver care to our geriatric population. Specialized geriatrics care, however, is being delivered mainly by specialists in geriatric medicine and geriatric psychiatry. All these physicians require the skills to care for older patients in an interprofessional team setting, whether they occur at the community level, the acute care level, or rehabilitation level. When we look at the model of health service delivery in geriatrics in Canada, there are multiple different domains that interact with each other. For instance, primary medical care oftentimes involves multidisciplinary care, team-based case management, as well as preventive geriatrics. These clearly interact with various programs such as adult day programs, supportive housing, and assisted living programs. Specialized geriatric programs also interact with primary geriatrics programs. These specialized programs include entities such as outreach activities, geriatric rehabilitation services, geriatric day hospitals, geriatric rapid access programs or teaching clinics, geriatrics or acute care consultation programs, short stay assessment and treatment programs, geriatric evaluation and management units, as well as acute care of elders units or ACE units. For many seniors, the point of entry into the health system may in fact be the emergency room or other hospital setting within the acute care system. From a scholarly and research productivity point of view, Canadian researchers and geriatricians are well positioned both nationally and internationally. The following couple of slides illustrate some examples of leaders who have been recognized nationally and internationally for their work in geriatrics research. As you can see, the number of topics vary tremendously, ranging from acute care for elders to bone health, cancer care, delirium care, dementia and cognitive impairment, diabetes, driving, falls, frailty, cardiac physiology, urinary incontinence, nutrition, pain syndromes, polypharmacy, quality of life, vaccination, etc. In fact, we are delighted that the Canadian Geriatrics Journal, which is the official peer-reviewed scientific or research journal for the Canadian Geriatric Society, is now part of PubMed Central and is indexed by the U.S. National Library of Medicine and the National Institutes of Health. This is the culmination of the tremendous work of a large number of Canadian geriatricians in the past many years. In the meantime, we are also delighted to present a Canadian Geriatric Society Journal of Continuing Medical Education. This particular CME journal is focused for primary care physicians and other physicians, whether they are in specialty practice or not, who are involved in delivering healthcare needs for seniors in Canada. In order to become a geriatrician in Canada, there are a couple of different training trajectories. Training in geriatric medicine is a Royal College certified program. It involves 3 core years in internal medicine, plus 2 subspecialty years in geriatric medicine. Residency in geriatric medicine in Canada must include 1 year of clinical senior residency in geriatric medicine, plus another year of either clinical or laboratory-based geriatrics research training. Alternately, training in healthcare of the elderly can be achieved for physicians who are trained and certified by the College of Family Physicians of Canada in family medicine, which involve training for 2 years, plus another 6 months of enhanced skills training in healthcare of the elderly. At the present time, there's no certification examination for this particular training route. The Canadian Geriatric Society is proud to present a set of core learning competencies for medical students in undergraduate medical education in Canada. These competencies are accessible through the Canadian Geriatric Society website, which is at canadiangeriatrics.ca. In terms of postgraduate or residency training, clinical rotations are available across Canada and may be either elective or mandatory in nature. The amount and scope of geriatrics content vary, but recent years have seen a substantial increase in the internal medicine examination blueprints, for instance. Core competencies need to be developed at postgraduate residency training in order to ensure maximum and optimal exposure of residents in training so that all of them are empowered to delivering care to our aging population in Canada. When we look at the number of entry positions into the field of geriatrics, we are encouraged by the recent national expansion of both family medicine and internal medicine postgraduate year 1 entry positions. These include expansion into distributed medical education sites across Canada. What these have also meant is a subsequent expansion in the number of healthcare of the elderly and geriatric medicine training positions. However, expansion alone may not be the only answer because not all positions available are necessarily filled with trainees. For instance, in the Canadian Residency Matching Service, or CARMS Medicine Subspecialty Match, recent statistics have shown that the number of positions in geriatric medicine have actually increased. For instance, there were 25 positions in 2010, and this number has increased to 31 positions in 2011. In terms of the number of positions filled, however, 8 of these positions were filled in 2010, representing a 32% filling rate, and 13 positions were filled in 2011, representing a 42% of filling rate. These numbers, in contrast, are substantially lower than many of the other medicine subspecialties that enjoyed overall 85% or higher match rate in both years 2010 and 2011. Even though geriatric medicine training positions have expanded and in fact are protected in some provinces to ensure healthy numbers of entry into geriatrics training annually, subspecialty training in geriatric medicine has not been sufficiently attractive to internal medicine residents. this is likely a multifactorial issue and will warrant further work. This will need to be addressed in collaboration with the Ministries of Health and other stakeholders, including faculties of medicine at various universities across Canada. In some jurisdictions, a formal needs-based model for postgraduate medical education planning has been implemented. In fact, in many provinces, the Ministries of Health and the faculties of medicine actively discuss human health resources, and they would like to focus expansion on areas of need such as the aging population. Geriatrics is clearly on the center of radar screen. To address this, the Canadian Geriatrics Society has commissioned a special report on health human resources planning for geriatric care in Canada. At the Canadian Geriatrics Society, one of our strategic directions is to improve the image of aging and caring for seniors amongst our health trainees. In this regard, we're delighted that two organizations have been structured in recent years, and they are the National Geriatrics Interest Group, or NGIG, which are focused for medical and healthcare students, as well as the Resident Geriatrics Interest Group, or the RGIG, which is spearheaded by medical residents with an interest in the field. Both of these entities comprise of local chapters with central support and coordination and facilitation from the Canadian Geriatric Society. The NGIG organizes student-focused activities such as research workshops, and the RGIG actively delivers health advocacy programs to seniors in the community on a volunteer basis. Both of these groups organize social events to raise awareness and offer peer support amongst trainees who share a common interest in the career of geriatrics. At the Canadian Geriatric Society, other strategic priorities include consolidation of the recently PubMed indexed Canadian Geriatrics Journal, as well as consolidation of the CGS Journal of Continuing Medical Education. We have also embarked on developing a renewed communication strategy that features a more user-friendly CGS website, as well as a quarterly newsletter to reach out to our various audiences. As mentioned previously, we are delighted that the NGIG and RGIG have really done very well for our up-and-coming medical students, residents, and fellows with an interest in geriatrics. Meanwhile, we have augmented our working relations with other geriatrics associations, both within Canada and internationally. And last but not least, we have launched a membership recruitment campaign with a focus of engaging new members. And at this point, we would like to extend a warm invitation to all of you to join us at the upcoming 33rd CGS Annual Scientific Meeting, which will be held in Toronto, Ontario, from April 18th to 20th, 2013. We believe this will be a tremendous opportunity for networking and learning. Thank you for your attention, and we hope that you will enjoy this podcast presentation. Goodbye.